Good afternoon, everybody. I know it's a little bit early still, but we'll try to start in a couple of minutes. Let's see how many people we have. We have a few people online, 2 or 3. I'm Tavio Akimascu. Welcome to our Implementation Science for Innovation and Discovery series. This is our monthly educational program on implementation science and contingent disciplines or adjacent disciplines. We are very lucky today to have Dr. Matt Scanlon from our own institution here at Medical College of Wisconsin. He's the professor of pediatrics and critical care medicine and co-director of quality improvement and patient safety scholarly concentrations. And he's a worldwide known expert in the fields of pediatrics, critical care medicine, health, human factors, engineering, safety, and quality improvement. So without further ado, Matt, come over and talk to us about patient safety.
Well, thank you. So thank you. Today, there's a couple issues I'd like to talk about that I've alluded to here. First of all, why after decades of investment in trying to improve patient safety, I would argue, and it's not just me, there's evidence behind this, that we have made very little improvement. And secondly, what are the potential opportunities for implementation science to make a difference? Originally, I said can make a difference. I'm old, I'm cynical. I changed it to might because, as you'll see, there's some hurdles. I have one disclaimer which I will address. It's a non-financial disclaimer that I'll touch on shortly. But I'd first like to start with the patient story. And I know Megan and Lisa are on the call, so you know this story well. This is a case where a father brought in his 21-day-old infant to the emergency room where Megan works. The child had difficulty breathing. The father didn't speak English as a primary language, and so a video interpreter was used. And during that encounter, the provider learned that there were other sick children in the household. Unfortunately, the mother was the primary caretaker, and as is often is the case, dads only know so much about what was going on with the kid. So there was finite history available. Meanwhile, the provider seeing the patient was a rotating family practice resident on their 3rd shift ever working with children. So they had finite experience. And to that date, in those 3 shifts, every patient they had seen had a common viral respiratory illness called bronchiolitis. And this is a representative bronchiolitis picture. So the child was also diagnosed with viral bronchiolitis, admitted to the hospital because they had an oxygen requirement. And on the 3rd day of hospitalization, they had a cardiopulmonary arrest. Now, this is not the child's x-ray. So after successful resuscitation, the child was found to have an undiagnosed congenital heart disease. And so an investigation was performed that attributed the arrest to diagnostic error due to anchoring and recency biases. So before I go further, I wanted to give you context about why I think I'm qualified to speak on this with some caveats. So this is a picture, this picture, I'm pretty certain is the picture from BMJ's issue, the issue of the BMJ from 2000 that focused on patient safety in March specifically. And in 1999, the Institute, what was then the Institute of Medicine, released their report To Err Is Human, which described 44 to 88,000 Americans dying annually from preventable harm in healthcare, which they equated to 1 to 2 airplanes crashing every several days at the hands of healthcare. At that time, I was finishing my training in critical care here, and I got interested in quality improvement. So I started my training in this domain. And so in 2000, I went to Intermountain Healthcare where I did their advanced training course. And during that March, I was at Intermountain Healthcare when the BMJ issue came out, which really piqued my interest. And At that time, it was very difficult to sell quality to healthcare providers. I'm not sure it's easier now, but it was a non-starter. You'd say something about quality improvement, people would back away from you looking for the exit. So I then pursued formal training in patient safety through what was then the National Patient Safety Foundation. And I was children's first patient safety officer. The following year, I went to CPPS, which is Lisa Poputsky talked about CPPS last month, about the systems engineering to improve patient safety, which is just one model of thinking about socio-technical systems. And more recently, I finally finished my master's in human factors engineering through Purdue, all giving me different lenses to view healthcare. Around the 2000s, I had the privilege of working with the late Dr. Bensy Karsh on two R01s, where Children's was the site organization for investigating some really interesting research, some of which I'm going to share with you. And more recently, for 8 years at CTSI, I taught a course on safety, on patient safety and safety science, and I'll come to that in a minute or as we go along, as well as was mentioned, I'm the co-director of the Quality Improvement and Patient Safety Concentration for the college. Lastly, I've done lots of national and international work, but currently I'm involved with the Joint Commission. I've been their Pediatric Patient Safety Advisor since 2009. I've been involved with the pathway, which is now the concentration, since 2012. I helped create and write the certification exam for patient safety for IHI, and I'm working on their human factors exam. So I think when I put this slide together, I worried about trying humble bragging, which was not my intent. One, it struck me that I'm old. Two, this slide reminds me of how little I actually know about this stuff, even though I've been trying to learn for over 20 years. And so today I'm going to share some of that, which brings us to my disclaimer or disclosure. After all this time, I've come to think of these as separate domains that sometimes overlap. So I don't know how many physicians are in the room, but we do this. And there's also clinical research, there's other administrative, there's more domains that aren't displayed here. QI and patient safety have a lot of overlap with clinical care delivery, but what's interesting to me is the more I learned about this, and I'm still learning, the overlap between what I'll call safety science and human factors engineering in patient safety is disappointingly little, which is one of the opportunities and challenges for implementation science as we move along. And it's not just, yes.
I don't mean to interrupt, but you're not actually sharing your slides.
Oh, thank you for interrupting. I don't know why that is.
I can see them on the back screen, but I can't see them as a virtual member.
Okay on my end.
Yeah, I can see them too.
Oh, I don't know, Megan.
I can see them too.
Okay. I'll send you the slide deck, Megan.
It's just a me problem. Sorry.
Okay, no worries. Okay, so the point of this is I think if we are ever going to make healthcare safer, we're going to have to increase the overlap of safety science and human factors engineering with these other domains. So the central premise of my talk is that healthcare is not particularly safe. So let me share some evidence for that. This is a paper from 2016, which raised a lot of eyebrows, and Macri and Daniels published looking at a number of data sources and concluded based on their analysis that medical error was the third leading cause of death in the United States. Now, there's a number of people that have issues with their statistics. I'm not going there today. I have an issue with medical error being the cause, and we'll come to that as we go along. More recently, David Bates and his colleagues replicated much of the original studies that were done in that were cited in the IOM report. And they found that adverse events were present in nearly 1 of 4 hospitalizations. And of those, another quarter were viewed as preventable. So another way to put this is we all have skin in the game if you ever end up in the hospital. There's a real risk that something bad may happen to you despite our best efforts. Dr. Ken Catchpole, who is a collaborator of myself and Lisa and Megan's, he and I wrote a letter to the New England Journal, which was published, responding saying, this is not surprising. We were totally unimpressed with the findings. The research was good, but the conclusion was not surprising for at least 3 reasons. And I'm going to take you through those 3 reasons today. The first of those reasons is healthcare's error of focusing on error. So many of you may know the constructs of slips, laps, and mistakes. In slips and lapses, you've mastered a subject, and then you either just start doing the wrong action or you miss a step. So if you've ever on a day off found yourself driving to the medical school, that's an example of a slips. You slip, you just go into autopilot. You've automated this behavior, and that automating of behavior, multitasking is alive. We task switch and we automate behaviors. The automating of behavior is really useful, particularly when you're driving, until something appears in front of your car, in which case, if you're tuned out to driving, you have what's called an accident or a collision. Lapses are where you know the process well, but you miss a step, whether it's forgetting to add water to your coffee maker and then wondering where your coffee is, or in a clinical procedure, forgetting a key step, which then introduces risk to the patient. All those are well described. Mistakes are this concept of where you either apply our if-then rule. So you've learned, and it's interesting that it's July, because we've unleashed a group of people that have spent the last 4 years memorizing if-then statements, hoping that the patients all follow the rules. So one challenge is when you apply the wrong if-then statement. The other challenge is when you don't have any rules and it's a black box, and so you have to figure it out. And that's how we think about these. Unfortunately, when we start to explore what safety science talks about, here is a sample of it. And this is goes back nearly 25 years. This is not complete by any stretch. And these are all publications, and if anybody wants any, I can provide them, talking about how human error is not a cause. It's a social construct like religion, race, brain death. We made it up to explain a phenomenon we observe, but it is not an observable, measurable thing. And in complex systems like healthcare, it is never a cause of a bad event. It may be that you can identify an error in that process, but as far as a single cause, that's nonsense. And because we've been focusing on errors, despite recommendations otherwise for since 1999, this is one of the major factors that has led us to not make any progress. Now, what's interesting is the IOM report talked about errors, but they didn't tell us to focus on errors. They actually said to talk about socio-technical systems, or systems, they said. And Lisa shared this slide, or I think she shared this slide, or a version of it, but these are different versions of the SEEPS model. This is a model of socio-technical systems. Let me de-jargon that. Socio-technical, for those that aren't familiar, people, technical, anything that's not a person. So readily you see that healthcare is a socio-technical system. We have people and stuff, and together we are working to achieve a task or a number of tasks. And what these models talk about is, first of all, you can never have a people problem versus a person problem, or versus a systems problem, because the model or the system by definition includes people as an integral component. It's like saying I have a body problem or an arm problem. I mean, my arm is part of my body unless it was cut off or something. So it's nonsense to draw that distinction. The people in this, as well as the rest of the technical elements, are part of the system. The second take home around this is that the same system that creates good outcomes is the same system that creates bad outcomes. And that's really hard to wrap your head around. And the reason that's true is because of the interactions. And it's the interactions of the components at any given moment that determine whether a task is successful or not. That's why you can have the same OR team working in the same environment day after day and have variable outcomes. And it's not because we will say somebody screwed up. That's one of our favorite pastimes as an industry. But it's the interactions of those. And because we have so many people involved, both the patients, providers, and the people behind the scenes, we have the issue of all of us bringing our baggage into that environment. So if I had a fight with my significant other, if I'm getting sick, if I've been up a stupid number of hours, all of those things affect my performance, never mind just the limits of human performance in general. To illustrate the impact of looking at it from a socio-technical lens instead of a human error lens, I want to revisit that case study we started with. And Megan, Lisa, and I were part of a group that did something called a PET scan. Now, PET stands for People, Environment, Tools, Technology, and Tasks. The only thing I don't like about the name of it is they left off the I, and I would argue the interactions is the most important part of this. And specifically, we went ahead and took that case and looked at it through this lens to say, what were the different components and how did they interact to lead to what was just labeled a diagnostic error? So we have these 4 buckets. Just to be clear, there's multiple environments. There's our physical environment, and the room here is quiet. We don't have anybody with a jackhammer outside. The temperature's reasonable. You have the socio-organizational environment. Well, that's decisions about purchasing, staffing. Do we invest in this program versus that program, as well as the rules, both written and unwritten. And one of the challenges when you go to a new organization is you have to learn all the rules that nobody tells you about. The third environment that comes into play is the external environment. And the best example I can give you, well, let me give you 2, CloudStrike and COVID. Those weren't internal to MCW, but they've ruined many of our days, plural, or months or year. So all those things have an impact on this working system. And when we started to take apart this case, we found there were multiple categories of people. And with the PET scan, you look and say what barriers and what facilitators are associated with that for the task of interest. And our task was, did the provider and the family together reach a correct diagnosis? We found physical barriers, social, organizational, external, barriers and facilities related to tools, and tasks. And I'm not going to take you through all this. It is going to be published soon, hopefully within a month, in Quality and Safety and BMJ's Quality and Safety in Healthcare. But this is part of the results. So if we think about the patient, or I'm sorry, the parent, there's my error. They had limited English proficiency, which impaired taking history. The parent was fatigued. There were potential cultural differences. There were siblings in the house that had a viral respiratory illness. So it was reasonable to think that this kid was coming with a viral respiratory illness. The parent was not a primary caregiver, and they knew limited history, which included the fact that the patient had been losing weight and poor feeding, which could be a cue that there's something more systemic going on. But that wasn't available to the providers. Meanwhile, the provider was at the end of the shift in fatigue. They were probably stressed, being their 3rd shift in a pediatric environment. All they'd seen is kids with a respiratory infection, and they had to use protective personal equipment, which we'll come back to, which aggravates communication significantly. So we went through each of the elements and identified these. But while looking at these, you can start to appreciate the messiness of making a diagnosis in the scenario. What's really interesting, I think, is when you get to the interactions. So let me give you an example. For the non-physicians in the room, 2 central parts of making a diagnosis is taking a history, asking questions so I know what's going on with you as a patient, and performing a physical exam. So in this case, the interactions between the inexperienced and fatigued provider with the fatigued non-primary caregiver was confounded by a noisy environment and reliance on a video interpreter to gather data. Additionally, the patient's medical records were not on a EHR available to the provider at the time. So there was history available that would have cued in that the growth was abnormal, but it wasn't accessible, so it might as well not exist. External factor influencing this work system. Similarly, performing a quality exam was aggravated by the use of PPE. This is the capper helmet that we would wear, or PAPR helmet. There's a fan in there blowing air out. So you have background noise of that. No one could read my lips, and I can't read theirs if they're masked. And then I use a Fisher-Price stethoscope to try and listen to their heart and lungs, which in a noisy environment, you can understand why some people quit listening. So all that interacts to make the two key parts of taking or reaching a diagnosis, it undermines those. You can look back and blame the provider for recency bias and availability bias, but the interactions are there if we go looking. And Eric Holnagel, I may butcher the acronym, described in one of his many writings. Eric Holnagel is a psychologist with a safety, who's focused on safety. WYLFYWF, which, to break that down, what you look for is what you find. If you go and look for error, you can find error. You can find something you can label. As you may know, there's the other abbreviation, WNL, within normal limits, or we never looked. And that applies in these scenarios. We don't go looking for the socio-technical elements in these complex system interactions. We just say, aha, we found the culprit, and today it's you. Declare victory, and then we don't make any difference. Before I move on, any questions about this? Because I realize this is territory you may not be familiar with, so, or pushback. Okay. So I said there were three reasons that Ken Catchpole and I argued for. The second reason for why Bates's findings that adverse events were no better than historically was that we've not studied healthcare delivery. We spend billions, trillions on studying the human body, studying disease and therapies, but we don't study how we deliver healthcare. And there may be exceptions to that. I mean, I'm speaking in generalization, but as a rule, NIH and AHRQ don't fund big parts of their budget to understand what's the best way to deliver a medication. What's the best way to communicate with the family? So this is a 2011 paper that talked about the doubling rate of medical knowledge. And in 2011, they projected that the doubling rate in 2020 was going to be 73 days. So the amount of stuff that our medical students and us as providers should know is theoretically doubling every 73 days. This is data from McKinsey talking about DNA test adoption, telehealth adoption, and I would point out this is Medicare dollars pre-2020 because you know that exploded during the pandemic. And then as the cost of genome sequencing is dropped, all these things take an industry that was incredibly complex and made it exponentially more complex. We, again, are held up as the most complex industry known to humans, with software engineering probably number 2. I couldn't find data, and I'm sure it's out there, but I couldn't find, I wasn't posing the right question, and searches seem to have deteriorated with the advent of AI, that on the rate of growth of medications, the rate of growth of biologics, but that's another degree of difficulty that's been thrown in this. And so when you look at the interaction of all these and regulations and the fact that we're keeping patients with more complexity alive longer, it's a mess, and we're not paying attention to the complexity at all. And that's important because of something called the archetypes of work. And these are only a few archetypes of work. There's a great blog written by a psychologist named Stephen Shorrock. Stephen Shorrock is a human factors engineer who works for Eurocontrol, the air traffic control agency for Europe. But he does write about healthcare quite a bit. And he describes these different mental models we have of work. And two of which I want to point out are work is imagined versus work is done, because I think these things haunt us on a daily basis. So let me give you an example of these. I want you to think back a week from yesterday. So not Sunday yesterday, but the Sunday before. And I imagine if you're like me, a number of you were thinking about what you were going to get done that week. So you thought on Monday, I'll do this. On Tuesday, I'll do that. Finally get this off my desk on Wednesday. And then you get to work. And what happens? And then you have CrowdStrike or whatever, CrowdStrike, whatever it was on Friday. And oh, I can't even access my computer. So I'm not getting anything done. That's work is done. The difference is, you know the difference. You imagine what you were going to do. Work is imagined. You then met the messy reality. The problem is in healthcare, we have no clue about what work is done is, but we have imagined models of how work is done, and we write policies and procedures on them. We hold people accountable based on them. And I would argue a lot of QI work, I have formal training in QI. I think there's great promise there, but a lot of it falls short, I think, because of this, because they're planning interventions based on what they imagine the work to be is rather than what it actually is. So during one of those early R01s I was involved with, we incidentally stumbled across this. And we were looking at nursing work and how it was impacted by medication barcoding. And so to do this, we had to capture what nursing work was. So we spent close to 100 hours with trained observers shadowing nurses in 6 different clinical domains, 3 at Children's, 3 at Vanderbilt, all pediatric. And we would observe the nurses' work, capture it in a tablet, and then afterwards, when there was a downtime, we'd say, you know, last time you did this time you did that, what gives? To try and capture that. I don't think any of you work in pediatrics, but I think at least some of you have seen medications given in the inpatient environment. So ballpark, how many steps do you think are involved? 12. 12? Okay. That's a very common response. Anybody else want to venture a number? So I've asked this by now, probably of 1,000 people of different backgrounds. And the numbers typically respond from 3 to 12. I went looking to see, is there anything published around this? And this is firewalled by a pay site. Unfortunately, I have the URL, but I had an old screenshot. Here, this, from a general internal medicine ward, they identified 4 steps, whereas this is from an online nursing textbook. And depending on how you count, it's 7 to 12 steps. Okay.
I didn't see your slides.
I know you didn't. So when we were done, we created a flow document of the steps. We presented to the nurses, got feedback, and revised it. The first thing to know is the flow document was not linear. We love linear flow diagrams, but in reality, that doesn't happen. These are 2 screenshots from the 44 pages of nonlinear work that we observed the nurses doing. This was in the paper world, so I don't know that it's gotten any less complex. And the other thing that's terrifying about this is we only have data around their observable work. We have no information about their cognitive work. So you can take and make this a lot more messy than what I've captured here. 3 to 12 steps, 44 pages of nonlinear work. Work is imagined, work is done. I view healthcare as a black box. We don't know what is going on most days. And some days we get insights to it. And when we talk about accident investigation, I can touch on that in a way to maybe close the gap between work as done and work as imagined. But the complexity is only growing. There's a third reason I said that of why things aren't safer, and that is we have excluded the safety scientists. So this is kind of like saying, if you'll bear with my analogy, you know, we don't really like gastroenterologists. We're just going to not have them at our hospital. We'll just get rid of it. I mean, yeah, they're experts in the gastrointestinal system, but, you know, they don't make a lot of money. In healthcare, and this is a great read if you haven't read it, Bob Wares unfortunately died. Kathleen Sutcliffe, you may know, she helped describe HROs, high reliability organizations, a number of years ago. Bob Wares was an adult ED physician and a human factors expert. And this book describes their bias on why healthcare isn't safer. And it overlaps with many of the reasons Ken and I articulated. But what's interesting is in the 1980s, anesthesia was unsafe in the US. There was a lot of injuries and deaths during anesthetic practice. And so at Brigham and Women's and at some other hospitals, they said, we need help. And they brought in engineers and psychologists. They need to do this from studying human factors engineering. And I might have mentioned this last month during our discussion. There's citation I'm not showing you from 1947, which is a case of over 400 plane crashes in the military, which was really the dawn of human factors engineering. And all of these, this was a problem because the US military was having experienced pilots wreck very expensive airplanes and often die, and they were all blamed on pilot error. And so they brought in some psychologists, and Fitz is one of the two. I'm blanking on the other guy's name, but there's actually a pretty good YouTube video about them. And what they did is they started studying the cockpit, the work system for the pilot. And what they discovered is that those accidents were all predictable based on the design of the cockpit. They would have levers with very different function with the same handle. So if you grab the wrong one, you wouldn't know that. There was nothing about the shape of the handle to say, hey, don't grab that dummy. You're about to do something really bad. The way the data was presented set them up for failure. That led to the dawn of human factors engineering and starting to look at our work systems to say, how do we make them safer? In the 1980s, we brought those people in and they made anesthetic practice much safer. Why don't you put diesel in your gas tank? Anybody?
What type of gas?
Why don't you put diesel fuel in your gas tank or the tank of your gasoline running engine? Does anybody know?
So it doesn't allow you.
You can't. They redesigned the nozzle. Back in the 80s, the interface on the wall for different gases, nitrous, air, and oxygen, were all the same. So a stress tech changing the room gets them confused. The anesthesiologist goes to give 100% oxygen. They're delivering the wrong gas. Okay. It was really promising. And in the late 90s, the Annenberg conference was one of the first safety conferences. They had the safety scientists in the room. Well, then us healthcare workers got in the way. And that's a lot of what this book is about, where physicians, nurses, pharmacists, and administrators said, yeah, we got this. We don't need you anymore. We'll do your gastroenterology and we'll do your neurosurgery also, because we know what we're talking about. So this is a chart I created out of the book Display by Sidney Decker, recapping a history of the safety science movement from the Industrial Revolution to present. And I'm not going to take you through all this. A couple key points. Taylor in the 1910s and Heinrich are a lot of, I'm of the school of thinking that they're a lot to blame for where we are, because Taylor said, oh no, our systems are well designed, they're understood, and it's people being bad. Heinrich doubled down on this and said in the 30s, oh yeah, the problem is behavior. And so we focus on human behavior. In the 50s, 60s, 70s, systems safety started, a view of things as systems started coming to happen as a result of the involvement of human factors people. 1990s Swiss cheese, we'll talk about that, and they've moved on. We're kind of stuck in Heinrich and Taylor's world and in Swiss cheese from a patient safety standpoint. I still regularly see the Swiss cheese model presented at meetings. That should be a sign to get up and leave the room in case, unless they're telling you it's garbage. That's the scripted part. Here's the unscripted part. These are examples of things that patient safety has championed that aren't evidence-based, which I think offers a huge opportunity for implementation science. If implementation science is bringing the evidence into practice, we can start with these, what I like to think of as the sacred cows or the usual suspects. So I would like to walk through some of these, but if there's any that you really want me to touch on, I'm happy to start there. I'm adaptable. Okay. So here's the Swiss cheese model, and many of you may have seen it. It is highly useful for people to start thinking about events. You have these nice linear defense. You've got this, each slice of cheese represents a defense, and the holes of them are considered latent errors or hazards, more appropriately. And some days they align and bad things happen. The problem is that this is a non-dynamic model. It is linear and suggests, like dominoes, that events happen in this straightforward, played out way, which has led, and these books are old, strictly speaking, unscientific, reductionist and linear, and focus on causal series rather than complex relationships, which is why it's great for a early learner to understand the concept, but then we need to stop talking about Swiss cheese and plugging holes in our daily operations. And this reductionism comes back to haunt us over and over again. Safety and the lack of safety are thought to be emergent properties of systems that are greater than the sum of the parts. A lot of healthcare has come through reductionism. We will take and understand the components of a cell, and thus we purport to understand the cell's behavior, which sometimes works. Another thing that's terrifying to me, this paper, which is, I forget, 1981, I think, 91, JAMA. This is terrifying for all of us. So this was a study where they took a group of cases from an anesthesia malpractice database, where all had been reviewed by peers and found to meet the standard of care. But there was a question, which is why they were in this database, okay? Then they changed they would take the cases and change the punchline to either from temporary harm to permanent harm. They sent them out to reviewers, and in a statistically significant fashion, if there was permanent harm, the trained anesthesiologists who reviewed the cases said it failed to meet standard of care. Everything that they did were already approved as meeting standard of care. But the bad outcome in Western civilizations clearly biases us. This is outcome bias. And we will find fault when none exists. Now, I don't know what all of you do every day in your day job, but I have a feeling there are bad news that you have to share with people periodically. And the problem is, people are going to say you screwed up, or your team screwed up, or you failed to deliver good care or do your job right just because of the bad outcome, which is terrifying. And this is a well-described, no one that I'm aware of has reproduced the study. I've always thought that would be a fun study to reproduce, and outcomes bias is evil cousin brother is hindsight bias. So this was drawn by the late Richard Cook, who was an anesthesiologist and human factors expert. thinking about the complexity of decision making. And the problem in many of our healthcare environments, and I think for those of you who aren't on the front line, you have your own version of this, is you have to make decisions with the available information, often under time constraints. So you do the best you can. That's the local rationality principle that Henry James described, which says that we're not going to work to screw up. We're going to do the best we can with the information. Then someone looks back in hindsight with all the information in front of them, draws a nice linear, oh, here's where you went wrong, and then proceeds to tell you how you screwed up. This is important because if you stop and think about our accident investigation, and I'll get to this in a second, it's all based on something bad happened, and then we look backwards after we've had a chance to look at everything. The provider, or whoever in the context, the guy at the tech company on Friday, again, they were doing what they thought was right at the time based on the cards that were played. In hindsight, we can say here, oh yeah, you screwed up badly. The other thing that's really insidious about hindsight bias is now you all are aware of it. You've joined the guerrilla movement against hindsight bias. The problem is it won't matter. Knowledge of hindsight bias, and there's some really cool old psychology experiments, knowledge of hindsight bias will not prevent you from applying it. There's no vaccination against hindsight bias, and half our country wouldn't take it. So we're in deep trouble.
Now, isn't this at the core of how we use root cause analysis?
You said you didn't look at my slides, but
I did not.
Okay, so this is one of several publications, I didn't include them all, taking down root cause analysis. So if I was to touch on the problems, and there's lots of them, one, already the name it's a misnomer. There's no such thing as a singular root cause. There are causes in a complex system. Those causes or contributing factors interact. But to say one was the root cause is absurd. The other thing is there's no primacy to the causes. Because if you took away any of those contributing factors, it wouldn't have happened. So they're all equal weight, but we like to assign, oh, this is where to go. Now, from sociologists and other researchers have looked at how we do root cause analysis. And some of this is from the UK, so you can just blame them as being different if you want. I don't think that's fair. But we know the following. These are not timely, they aren't performed in a timely manner. It's very difficult to get the frontline workers who are involved there. And when they show up, usually they have someone senior from their tribe there to protect them. So there's an exercise in tribalism, and whichever group tends to have the clout or the oldest white male yelling tends to carry the greatest weight, very wrongly. There's a nice study that shows that they looked at people going to root cause analysis, and all of them were coming with the solution they thought was applied before there was any discovery. They already said, these are negotiable, we'll do this, anything else is off the table. There's another paper that talks about an OR table, which was known because of the fact that they need to rotate patients. It's known to be associated with patients falling off. The correct solution would be buy a better table, but the cost of the table was prohibitive. So they picked weaker solutions, and I'll give you examples of those in a little bit, and didn't make a difference. Which led to this paper coming out in 2020. It's time to step up. Why safety investigations in healthcare should look more to safety science. Now, I showed you that timeline of safety. I think it's important to acknowledge there are different camps in safety science. Safety, the body of science, the group of scientists performing research into safety is not monolithic. They've got their own agendas, and a lot of it reflects their training. And Lisa last month talked about that with human factors engineers, that if you're from an engineering school, you take a very engineering mindset, where if you're from a psychology school, you have a different lens. So I'm going to share a couple different approaches as alternatives to root cause analysis. There's a paper that came out of Madison, Wisconsin, that I've used a lot for teaching about a case in the OB in a delivery room where a nurse gave an epidural medication IV instead of the antibiotic, leading to the mother's death. And the investigation concluded there were 4 things that were done. We applied, a group of colleagues and I applied a different technique, AXIMAP, which allows you to look at what external factors came into play, what organizational factors, what direct causes, and what were the outcomes. And this starts to show the messiness. This is not exhaustive. AXIMAP, and one of my partners, when I've talked about this in our critical care patients or safety lecture series, he always likes to push back appropriately. Yeah, but if you're going to half-ass do root cause analysis, you'll just do a lousy job with this. There's nothing to guarantee that you're going to do the diligence, especially if there's organizational reasons why you're protecting your tribe. Etsy, the shop to buy supposedly handmade stuff. This is their accident debriefing guide, which blew me away. John Alspun, I don't think he's there anymore. But he and David Woods and Richard Cook, before Richard died, created a company helping people learn how to do investigations. And one of the things that I can say in my 5-year tenure as a safety officer and in all my years hanging out in patient safety circles, I've never seen a course offered on how to investigate an accident. We just know how. Well, we'll just 5 whys. If we do the 5 whys, we'll understand. That gets to HOP and learning teams. HOP stands for Human Organizational Performance. So the goal of this, they fully acknowledge we are not going to ever understand why an event happened, and we're not going to try to. Right there, that's a huge departure from healthcare. They say, no, what we should do is use this as an opportunity to say, we don't know how our work is really done. We know how we imagine it. So let's debrief around what happened and what people's thought process were to try and shed greater light on work as done, and then disseminate that to everybody in our organization so that because they weren't part of the investigation, they don't get to learn about it. It's a totally different mindset. There's a guy named Todd Conklin who worked at the Los Alamos facility for years doing safety. And there's a website, if you search HOP and accidents, you can find there's a number of resources where there are healthcare organizations starting to play with this, to say, what can we do differently in healthcare besides root cause analysis? There's lots of other techniques. And again, some of them show the biases. These are STAMP and CAST. STAMP, if I'm not mistaken, is proactive. CAST is the after an event. This paper I learned about last Monday at an ongoing safety series that I'm part of. Nancy Levinson, who is a mover and shaker in the safety world, she helped investigate the shuttle accidents, among other things. She's been working with Memorial Sloan Kettering and other groups trying to apply their methodologies, which are engineering methodologies, to different safety events. And what's interesting is they had an event where, because of the interpretation of lab results, a medical practitioner prescribed the wrong treatment for a patient. I'm not going to take you through all of it, but that's what they found when they started to dig in the different layers, all the way up to Congress and the White House, the checks and balances, or lacks of checks and balances, for feedback loops that all contributed to this. And this report was prepared for or is being presented to the government because they want to learn about this. I haven't read the whole report. I don't know how many hours this took, but it's a lot more than most healthcare organizations could put into their investigations. So I think the challenge is, how do we learn when we have finite resources for doing this? But my intent here is to give you the range of what people have been doing. I don't know why that's there. Checklists. We love checklists. This is a great paper that Ken Catchpole and Stephanie Russ wrote a number of years ago. talking about the fact that a checklist is a change to a complex socio-technical environment. If you bring a checklist into an OR or into an ICU, that's a complex environment, and you're bringing something in, and then you just think it's going to be benign and it's going to work. And they contrast that with aviation, where their checklists typically have 3 items and their statements. Flaps up? Yes. Not, I'm using this to audit myself, and there has to be discussions about this with the whole team. We've misapplied the entire science, and there may be great value in these if we knew how to apply them correctly. Again, what is the evidence? How might we actually bring it into healthcare? As part of that medication study I was part of a million years ago, we surveyed nurses, and it was pretty good. We had like a 70% response rate, and it was a 14-page survey. So I don't know how we pulled that off, except they were very fired up to describe their work. And one of the questions we asked them was about their compliance with checking patients' IDs. Now, again, this is years ago that we did this. And we asked them on a Likert scale, a little of the time or some of the time, or a moderate amount of the time or more. We combine those. How often do you violate or work around checking the patient ID? In under routine and emergency situations, range from 75 to 91% of nurses said, some of the time I do that, or a lot of the time I do that. We asked them why. And this is where I love mixed methods. This is interesting, but why? And without the qualitative component, you don't know anything. We asked them why, and they said, I know who the patient is, stupid. I've been caring for that patient all week. You think I don't know who they are? Telling me to check the ID is absurd. We've misidentified the problem. We've mismarketed it. If I said to the nurses, dear nurse, sometimes someone puts the wrong medication in the med drawer, so we don't care if you check the ID, but you need to match the medication to the patient. This is a matching problem. Freighter's ED, I'm sure, gets patients without IDs all the time. And they don't say, oh, well, we would care for you, but you don't have an ID, so vaya con Dios. No, the issue is matching care to the patient. I told then head of Joint Commission, Jared Loeb, this. He did not like that. He yelled at me. So this is the problem we have. We've taken a concept and we've run with it without understanding what really is important. Situation awareness is a concept that I believe originally came out of aviation. And there's 3 core elements that, I'm blanking on her name, Ensley described. The need to perceive the elements in the environment, the comprehension or understanding of the situation, and then projecting what's going to happen next. And that's kind of a continuation. In healthcare, we've taken this concept and we've used it as a new way of blaming people. Oh, doctor, you lost situation awareness, as if it was something I ever had in a bag that I carried around with me. What this paper and others talk about is distributed situational awareness. Do the team members understand what's going on and what's likely to happen next? And this is an area that I think healthcare is starting to learn. So in our morning huddle in our ICU, we identify high-risk patients, and we talk about why we think they're high risk. Now, sometimes it's the non-high-risk patients that get in trouble. But at least everybody at 7:45, between 7:45 and 8, have a shared mental model of who's at risk in that moment. And then if things change, we update that information. That's trying to create shared situational awareness, not use this to blame. Quality improvement loves to blame variation as the problem in healthcare. I want you to think back about the 44 pages of nonlinear work nurses do in giving a medication and say that we haven't explored prescribing or dispensing, so we don't even know how complex that is. And then I asked this goes a few years ago, I asked the head of our pharmacy roughly how many meds we dispense to children's a year. And he gave me a number that when I multiplied it out was 941,948 medications a year. And I'm sure Freighter blows that away, VA as well. And then I said, how many serious medication safety events did we know about last year? So I fully acknowledge there's something that happened that we didn't learn of or we didn't attribute to it. The answer was 1.
See, it's very safe.
Well, the question is why? And it's because of people adapting in that system. The system is not, nobody designed a system with 44 pages of nonlinear steps for nurses to give a medication. But by them constantly adapting, that's what creates safety. And the problem is you reduce, so I think a variation is does it add value? Does it improve care? Or does it detract from care? This data out of Intermountain Healthcare over 20 years ago showed there was not a reason for every surgeon to have a different tray just because they wanted one. Now, if they could articulate good reasons why, then you should have that different surgical tray, but not just, well, I like the purple ones better or whatever. So the question is, if you start restricting adaptability in the name of stamping out variation, you limit our ability to compensate when things go south. And this is one of the issues that I don't think we've grappled with. The other thing that we haven't paid attention, well, there's a couple of things. Hazards. Hazards are things in the environment that cause harm. If you've taken an occupational safety course, they talk about hazards. We don't talk about hazards at all in healthcare, other than chemo or blood products. Here's a hazard. Heparin or Narcan, what do you want today? Sodium chloride or levobupivacaine? This one I'm really proud of. This is our DKA protocol at Children's, or guideline. I mean, how does anybody get it right? Fortunately, I was trained before this, so I just know what to do. But the providers are like, this is garbage. And the problem is there is a knowledge base to how to design these things. We could partner with people trained in usability and improve adoption. If you look at the literature on why providers are non-compliant with guidelines, they blame, oh, they're all cowboys who refuse to do standardized medicine. And they give other excuses. Oh, I found one paper that alluded to the fact that the guidelines weren't designed to optimize human performance. I mean, we could transform care delivery at the affiliated hospitals just by putting teams to doing that. And I think you would see better traction. Here's a hazard from our friends in Verona, Wisconsin. Without any notice to us, they changed an update, or they changed the system, and the default view was this, the first column of lab results. Does anybody see a problem here? 2018, 2024, all in the same column, as if they had anything to do with each other. The most recent result. So they took the most recent value from and I could have gone back further if with the right patient, and if there was a lab result, it put it in the same column. What is the likelihood that a provider misinterpreted that result and maybe made a bad decision? Oh, well, doctor, you screwed up. No, the system set me up, and those jerks at Epic don't want to help. There's a concept called information chaos. We looked at this in the electronic health record. Information overload, underload, scatter, conflict. We looked at 4 patients. Every one of them had conflicting information. They're 14, no, they're 3. Just crazy stuff that shouldn't be there. Wrong information, copy and paste. I'm not a Luddite. I like technology. These are 2 papers I'm very fond of, talking about the fallacies related with healthcare information technology, which I like to refer to as safety healthcare information technology because I like the acronym better. And these are some of the fallacies. Oh, well, bringing in an EHR or smart pumps is risk-free. No. This one's awesome. Healthcare information technology is not a device. you may not know this, but while FDA regulates all medications and all medical devices, EHRs get a pass. So they're not regulated by the same rules. They are not held to the same usability constraints. If we build it, the users will use it. Well, we won't need paper anymore. What we'll do is just have them check everything as discrete data, and then we can analyze it, which is great from a research standpoint, but doesn't tell you the patient's story. And if I'm forced to fill out boxes, you may get garbage going in. Certified as usable, clinical decision support will hear us, and so on. So lastly, let me just briefly touch on our approach to controlling things. And again, I mentioned occupational safety. This is OSHA's hierarchy of controls for hazards. So if you're working in a factory, the minimum, or I don't know, are the cranes working these days? I lost track of whether they're still on strike. But when the guys are building, PPE is the basic, that's the minimum. Wear your helmet, wear your steel-toed shoes. Administrative controls. We'll put up the sign saying 70 days since our last accident and be safe, or BPAs and EPIC alerts. Engineering controls. That's where we make it so you can't get to things. When Joint Commission passed, one of their two things I thought they did that was really useful was say, thou shalt not keep concentrated electrolytes in your units. They made healthcare demonstrably safer. I don't have a p-value, but you cannot give potassium to a patient by accident if it doesn't exist. That's the power of the hazard model. Replace the hazard. Once upon a time, I prescribed imipenem to patients. Was it imipenem? And then meropenem came along. And imipenem fell out of favor because it had a greater seizure profile. If I continue to use imipenem and put patients at risk, at that point, it becomes bad for care. But the gold standard is removing the elimination. This would be locking the potassium up. This is taking it away from the unit altogether. In healthcare, we flip this and we say, oh, our number one intervention is education and training. And most of that is not done consistent with adult learning principles. We love our administrative controls. We sometimes do barriers. We almost never eliminate hazards. And what's interesting is if you take and think about the SEEF squirt system model, it's not surprising that these aren't very effective because they're focused purely on the people, telling the people, don't screw up, instead of saying, let's figure out how we can make the system work better and less unsafe. So I'd leave you with this. When are we going to start applying the known safety science to healthcare and study those things we don't have knowledge of? That latter piece is huge. But there's a lot we know that we could be taking from other industries, from the scientists, and bringing in if we just put aside our ego. Questions, grievances?
What is the role of the expert in the system? You showed the initial X-ray, and I was attracted by the air bronchograms and the atelectasis in the right upper.
Yeah, which is common in bronchiolitis. And not surprisingly, often you get the cannot rule out pneumonia, so they get started on antibiotics for no good reason. So I didn't put HROs up there, high reliability organizations. Sutcliffe and Weick's, Carl Weick, that's whose name I was blanking on. I think their book is good. What's interesting, there's at least one paper, and I can't remember the author's name, that talks about the fact that those are characteristics associated with high reliability organizations. So for those who may not know, an example would be nuclear energy, or my favorite is a nuclear aircraft carrier. I mean, if you think about an aircraft carrier, first of all, I understand the concept of buoyancy, but it's hard to believe that thing floats. It's got a nuclear reactor in it. And then on a slippery deck that's covered with oil and water, they take planes loaded with explosives and fly them back and forth all day. And they're incredibly safe. So when Sutcliffe and White and others went to study these, they associated 5 attributes. Healthcare imagines, I think incorrectly, that if we just do those 5 things, we'll be an HRO, which is kind of like saying, well, if I dribble a lot, I'm going to be an NBA player. I mean, no, it does. I'm sorry. There are certain fundamental things that prevent me from ever playing in the NBA, starting with height and talent. So one of the attributes, though, is deference to expertise. The issue, though, is expertise is context dependent. And the expertise is not always the senior person in the room. I think that's where we go wrong. I did a project as safety officer where we were looking for things where things were not going well for bedside nurses. And when we identified a bunch of them, I said to them, you fix them. I got your manager's support. I'm not fixing them because I don't know crap about your work. The last thing you need is some well-intended physician telling you how to do your daily work. They're the experts in that context. When it comes to resuscitation, maybe they're not the experts. I don't invite them to intubate a patient because they're not the experts. The expertise is shifting constantly, which is one of the messy parts of healthcare. It's not clean. My favorite answer to a question in healthcare is it depends. It all depends on the context. I don't know, does that answer your question?
Oh, it does. And it's kind of a testimony to how complex and dynamic the environment is, right?
Right.
And we tend to try to fix slippages or accidents with very static frameworks. And that's kind of another recipe for disaster, right?
Right. I mean, even the SEEPS model is a gross simplification of things. So while I find it highly useful to think and communicate around these issues, I don't go around saying, well, if we just had a SEEPS model here, we'll fix everything. It is a way for people to take complex ideas and wrap their head around them.
So
yeah.
We're obviously entering the AI era.
Mm-hmm.
And there's going to be those that are going to be arguing that it's going to prevent anchoring bias and, it's going to take away all the background noise and focus and be more objective and just tell us what to do correctly. What do you see as the pitfalls of what, is going to be a simplistic model of applying AI versus the reality of it?
Do you remember my metaphor for healthcare, the black box? We're taking that and we're putting something autonomous in there. It's not what could go wrong, it's when will it go wrong. I get the idea, if MCW pays X number of people to copy and paste data into spreadsheets all day and we can automate that, there's a role for automation. But if you buy my premise that everything is context dependent, the AI is only as good as the learning model it trained on. And I mean, that's why let me start with a disclaimer. I'm not an expert in AI. I've read peripherally around it. There's a very funny blog post that I have saved where a tech person rants about AI and how it's doomed or we're doomed, which I'm happy to share or not. But the facial recognition doesn't work in lots of populations because it wasn't trained there. If we train it to read x-rays on certain people and then I bring in some variable it's never seen, it's gonna choke or give me misinformation. And I think the problem is how do the providers know when we should ignore that thing? It's the same as the if-then statements we teach students and trainees. The sign of expertise is knowing when not to apply that and what to do when you don't have any instructions. It's uncharted territory. And I think that comes with the development of expertise. Early on, it's just pattern recognition. Well, I don't know, maybe the AI can get smart enough to fill in the blanks. I'm pretty comfortable saying I don't have to worry about it because, I see 1-day-olds to 54-year-olds. With every disease under the sun, except small bowel transplants and pancreatic transplants. So, good luck, AI. I'll take that money. I worry about it. And I think Bitcoin was the answer. You know, we could just go down that. Still haven't gotten my money for that, or I haven't invested in it because I'm like, yeah, right. It sounds too good to be true. It is.
Well,
I don't know.
can't understand it. How can you invest in it?
Right.
Personally,
Yeah.
I'm in the tech space. I don't understand crypto.
Just give it. Well, it's pyramid scheme.
It's very simple, right? No, but do you think now the AI has a role in simplifying these process maps? If that 40-page process for the nurse to dispense the medication is too complex, depending on the setting, the patient, and so forth, do you think the AI has the ability to create a sequence of checklists that makes sense and it will make it safer for the patient?
I don't, because to me, that's going to be based on imagined work. The question is, the 2.0 study is to shadow those nurses again and understand why they're doing that and what they're compensating. There's a paper that I didn't call out that I'm very fond of called Why Hospitals Don't Learn from Failures by Tucker and Edmondson. And again, just email me if you want it. Anita Tucker and Amy Edmondson, who's now famous for psychological safety, they went into some adult hospitals to understand why things didn't go right. And their bias was the problem was human error. And they did attribute some of the things to human error. Now, again, based on my talk, I would take issue with that, but that's not their key finding. 80+% of things failing were what they called a problem, due to a problem. And they defined a problem as when something you need, supplies, information, or a person is not present at the time you need it, or something's in your way. And so for those of you who are in medical school, if you think back to during your rotations, how often you were the pack animal for the teams where you'd have your pockets stuffed with supplies. Because if the team needed dressings or tape or a hose, whatever, you were supposed to just provide it because they didn't have the time for you to go run it. That's called first order problem solving. And nurses are black belts in first order problem solving. You give them a problem, they will solve it. The problem is they don't always understand the unintended consequences of that. Second order, oh, by the way, first order problem solving is interesting because we tend to promote nurses who are really good at that, which doesn't mean they'd be good managers. They just don't complain and they fix things. So yeah, let's just put them in charge. And it's a recipe to burnout because if all you're doing is solving problems day after day after day, you get fed up with it after a while. And I'm sure we each have our own analogs to this, but they studied nurses. They contrast that with what they call second order problem solving, which is you deal with the task at hand, but you tell someone who makes that problem go away. And I think the issue is we don't think about that. And again, when I said did that project where I had the nurses fix things, essentially I taught them that paper, said identify first order, or what are the problem solving you do every day? And I gave them 2 constraints for prioritizing what they were going to work on. What has potential to harm patients and what is in your control? And you don't need another department or group to help. And they dramatically transformed some of their things. We had 3 stock rooms. They were all organized differently. So depending on which one you run into, it may take you 5 minutes to find something. If in a code situation, that's life or death. They standardized them. On our oncology unit, they could never find the blood pressure cuff that was on wheels. They took tape and made a parking spot for it, and they all agreed to bring it back. And it saved so much time for them that their quality of life improved. I don't know that we need and this is an issue that I always piss off the nurses with, but I don't know that we need to improve staffing ratios. I'm not saying we don't, but I think we need to start taking away the crap that nurses do that doesn't add value. That's something we don't, and every improvement group, well, how are we going to fix this? Oh, we'll have nursing do it. And yet I used to routinely say, great, what are you taking away? Never. So
it's about redesigning the workplace and processes based on potential
deference to expertise and bringing in the people that see systems differently. One of my favorite things to do pre-pandemic was bring engineers and psychologists into our ICU, and they would get this look of horror. And I'd be like, what? This is a quiet day. But between the noise and people running around, they thought it was insane. Well, the problem is I can't see that insanity. I've normalized that. That's where we need outside people with expertise to help us do that. And I think, just to be very careful, while I showed you all the training I've done, I still don't consider myself an expert in those domains. I know a lot about them. And I think I'm a useful Rosetta Stone to talking to those people. I mean, in a former life, I did most of an epidemiology master's, and I got pretty good at talking to statisticians. So I had a productive period in my career where I helped design studies because I could talk statistics. Do I want to do them? No. But could I talk to the people and understand why there was a gap? Yes. I've done that with engineering and to some degree psychology. It's not my place to be the expert unless I go get a PhD and work for 10 or 20 years in that field. And I've learned that I'm comfortable saying I'm not that person. I just know enough to know when we need the experts. Well, thank you.
Thank you. This was great.
This was useful.